Welcome to our podcast, EyeHackers. Professor Jean-Philippe Nordmann, the Chief of Glaucoma Department from Quinze-Vingts Hospital, previous President of the French Glaucoma Society.
Medical treatment and laser.
Many ophthalmologists still prescribe eye drops.
It's very simple to use. Most of the doctors don't have.
The main advantage is SLT compared to traditional glaucoma treatment.
How do you see the future of glaucoma in 10, 20 years?
That's the same thing for medical treatment and for laser treatment.
Can we predict in advance which patient will not benefit from it?
So it's quite straightforward. SLT is better than medical treatment.
Today is the second episode of our podcast, EyeHackers, and we are delighted to feature Professor Jean-Philippe Nordmann. He's the Chief of Glaucoma Department from Quinze-Vingts Hospital, previous President of the French Glaucoma Society, and also have trained many glaucoma doctors from Vietnam. So, bienvenue au Vietnam.
Thank you.
And thank you for visiting us again.
Thank you.
Could you please briefly explain what drew you to glaucoma? Why did you choose to become a glaucoma specialist? It's such a difficult field.
I agree that glaucoma is a little bit a difficult field, but however, there are many possibilities to cure glaucoma, to help patients, and really to solve the problem. And I think the reason why I worked on this field is that it's a very specific and open field where there are novelties. There have been many new medical treatments for a while. Now there are new surgical treatments, and that's why I think it's very interesting to do that.
Thank you so much. Today's podcast, we'd like to cover two very current topics of glaucoma treatment. The first one would be selective laser trabeculoplasty and some type of microinvasive glaucoma surgery, Preserflo. We'll not go deep into how it works because I think most ophthalmologists know, but we will dive into some interesting questions. So, please, Dr. Evgeny.
Thank you for visiting us and our podcast. So, question first is, many ophthalmologists still prescribe eye drops as the first-line treatment for glaucoma. Given that SLT has fewer side effects and improved patient compliance, isn't this approach updated? What are the main advantages of SLT compared to traditional glaucoma treatment?
I think continuing to treat patients with eye drop as a first stage is very normal and still not outdated. It's simply a big change. It's because previously laser was always after medical treatment, and now there is this possibilities to do it replacing medical treatment. So it's true that there is a tendency to do it for many reasons, because you don't have any more eye drops, there is no pain with the eye drops, and also you get a better IOP control. However, you need a specific device, the SLT laser device, that most of the doctors don't have, to repeat it every 5 years or so. So it's a new tendency, but it's normal to continue for many cases to use eye drops. And also I may say that patients are often afraid of laser. Mm-hmm. So we should not make them too much afraid by beginning a treatment that they may not consider as what they should have.
Should we start from medical treatment first if patient have a high level of IOP?
I think you can use both or medical treatment or SLT laser with high IOP. The expectation can be almost the same with the two possibilities. It's not a question of IOP. If the pressure is very high, you may not reach a very low level with any of this technique, and think maybe more about surgery than about laser or medical treatment. So it's not, both work well at high IOP. And if the pressure is higher than 30, probably you will need both, actually. Mm-hmm. Both medical treatment and laser. So you can really add both of these techniques.
And I think especially for glaucoma with normal IOP, normal tension, glaucoma, we have to use medical treatment and laser because we don't know which is lower level of IOP.
often you begin with one kind of treatment. You look if you have reached the target IOP, which can be like 30% less than the normal pressure. Then if you don't reach this, then you add or a second eye drop, or you may think about doing laser too. Or you begin by laser and then you wait and you add some medical treatment. And in low tension glaucoma, both of them. Actually, in low tension glaucoma, medical treatment and laser are not as efficacious as surgery. If you want to reach a pressure of 10, you may reach it only with surgery, probably.
Mm-hmm.
Yeah.
But in your practice, do you start with SLT or medication still?
There have been a very interesting publication published in the Lancet 2 years ago, which is called the LIGHT study, and they have compared 300 patients treated with medical treatment and 300 with SLT. And the answer is quite straightforward. SLT is better than medical treatment, and that I shift my way of treating early glaucoma. Now I more consider treating it with SLT laser, but again, some patients are afraid of that, and so I don't want to disturb them too much, so I can say, okay, we can begin with a small medical treatment. But however, I often say that if I would have personally a glaucoma, I would prefer SLT.
But we can see effect after SLT laser treatment in 2-3 months, not like with eye drops in 5 days.
Yeah, actually, it's not 2-3 months. It's more 1 month. And even with eye drops, you like for example with prostaglandins, you may find an effect on early stage like 5 days, but usually you wait for 1 month because some patients need more time to get the efficacy. So I would say in both cases you wait to 1 month to see the results.
Yeah. Studies show that the effect of SLT diminishes over the time, and many patients require treatment. Can we truly consider SLT a long-term solution or a just temporary measure delaying inevitable surgical intervention?
Both medical treatment and laser treatment don't have a final definite effect. And there have been a study in France showing that after one kind of drops, half of the patient needs a second one after 2 or 3 years. I mean, that's the same thing for medical treatment and for laser treatment. So it's both the first step. If it's not working for more than 2 or 3 years, then you can do again SLT actually. You know, surgery is also a difficult issue. You don't have always a good result, and you can do really 2 surgery in one eye in the life. So you should not go too quickly to surgery, because if it fails, then you may not have a lot of other possibilities. So it's not because SLT needs to be done again that you should think that it is not a good approach. It's a normal approach, like medical treatment, that often patients need two kind of drugs after 2-3 years. That's the way we treat this chronic disease.
In recent years, SLT has been widely promoted as a simple and safe procedure. Are there any risks or limitations associated with SLT that patients should be aware of? Is there a risk that is being overused even for patients who may not actually need it?
I would say that there are not a lot of risks with SLT laser. There is one first risk. If you over-treated the patient during the laser session, then you can have an IOP spike, which can be dangerous, especially if there is on dark trabeculum, if you put too much energy. So then this is a real danger. There are not a lot of other danger of doing it. But for the patient, one of the risks is that he could believe that as he has done laser, it's finished. The disease is over. And it's particularly a problem because you know that if you do laser for iridectomy, then you treat closed-angle glaucoma completely. So the patient has to understand that this is not the same kind of laser, and he should continue to control. So that and the other point he has, probably there are some patients who don't respond to laser. And it's often considered that juvenile glaucoma, post surgical uveitis glaucoma is not good issue. Post-retinal surgery glaucoma too with silicones or others are not good indications. So not all of the patients answer to SLT. And some also, maybe another problem is that some have a reduction of pressure very quickly. Reduction of efficacy very quickly means if a patient has a nice reduction of pressure and after 3 months the pressure goes up again, so it's not a good candidate. Yeah.
Okay, you partly answered for next question because it's about how we can predict which patient will not respond to SLT, because some critic points are out that SLT doesn't achieve the expected intraocular pressure.
It's very difficult to predict which patients may have a good effect or not. If you cannot correctly reach the angle, for sure, it's not a good indication because you cannot put really the spot on the trabeculum. But after that, it's difficult. And especially some patients have a really light trabeculum. So even with the higher power of the device, you don't get what you expect, like small bubbles of efficacy. But some do well, some don't. So it's difficult to know in advance the one who will not do well, unless you cannot do it correctly. Yeah.
Okay, so we have to inform patients that around how many
percent? I would say around 10 to 20 patients don't answer well to this. And after that, you have all the range.
Yeah, okay. How does the use of eye drops containing preservatives like benzalkonium fluoride after SLT or glaucoma surgery affect healing and long-term outcomes? Does it increase the risk of inflammation, fibrosis, or reduce procedure efficacy when prescribing artificial tears or IOP-lowering eye drops with this preservative?
This is definitely a big issue in glaucoma surgical treatment, is how long the patient have had before medical treatment. With preservative is certainly a big problem, for sure. So that's the reason why a lot of the glaucoma drugs don't have it with monodose or specific buffers in the bottle, but even sometimes without preservative. So for sure, a patient who have had a long-term treatment with eye drops have a reduction of the chances of having a good, efficacious glaucoma surgery. Normally, for dry eye, don't have any preservative. It should never have preservative because it induces inflammation. But in our patient, for sure, we have better results with patients who have had a short-term eye drops, and that's a good indication for using SLT instead. Yeah.
Because I know in my practice, I do not like when someone or myself prescribing eye drops after glaucoma surgery in 1-2 months. Because after surgery, sometimes we have
Of
IOP, yes, and if patient goes to another surgeon or doctor, he can easily prescribe.
Yeah.
Okay, and I think it can diminish results.
The results.
Surgery.
Often after glaucoma surgery, you use anti-inflammatory eye drops for the first months. Then it's a good idea not to give a lot after that. But actually, effect of the preservative are more long-term ones. Means I don't know if for short term this will change a lot the inflammatory reaction of the eye, but it's a good idea not to give and to wait a little bit, because in some cases then the things are getting slowly better. But all depends on the pressure you get after surgery and how the optic nerve can accept it or not.
Okay.
So today you have helped our doctors to learn how to do SLT, and you told us that we have chosen quite good patients for that procedure. So how would you describe the ideal patient of SLT, and what is your favorite machine to perform SLT?
The adequate patient is simply on open angle glaucoma. And as I said before, maybe not some inflammatory glaucoma, juvenile glaucoma, post regional surgery glaucoma, some small issues. So basically you have to see it well, and the trabeculum can be with pigment or without pigment. This is not the main issue. Well, basically we use a lot the LX device, which is doing quite well. There are others who are doing well too, but this one is very reliable, and that's what I like with this.
So you also have Alex machine as well.
We have.
So I
True.
guess here Alex Club,
Yeah,
small club of
but
Alex.
again, what I like with this one is this a reliable one. It's working well.
Thank you. So that was the first part of our podcast. Let's move to the second part, mix with Preserflo MicroShunt, which is getting extremely popular in Russia, in France, Japan, not in Vietnam yet, but I hope it will. So yes, please.
Yeah. The Preserflo MicroShunt, first used in 2012, I guess. Yes?
Yeah.
Isn't it? It is not an innovative surgical option for glaucoma. But during this time, many micro devices are on the market for glaucoma surgery. Could you explain the main, or maybe not main, difference between Preserflo and other shunts?
Yeah, what makes it so?
Yeah, actually, what we call mixed minimally invasive glaucoma surgery is a global term for many different kind of devices. Some only being plugged in the trabeculum, like the eye stent. Some trying to go from the interior chamber to the uveal scleral pathway, which is not like the CyPass. And then two main other one, the Xen device and the Preserflo, which is a small tube going from the inside of the eye to the subconjunctival space. So what is the specificity for me of the Preserflo that I am using a lot is that it doesn't move. Means when you put it in a place, it has no tendency to touch the cornea on one side or if you put it correctly or the iris on the other one, it stayed like it is. It's a very well designed tube, and also is never stuck with anything inside. Means the blood cannot block it. However, it can be blocked from at the tip, subconjunctival tip, by conjunctiva. So that's the main problem that we have. So I would say that it's very simple to use when you are used to it. It's not completely simple at the beginning, but it is not difficult. And for the one who are doing trabeculectomy, it's certainly safer than trabeculectomy because you get a pressure of 6 the next day, never 0, and so it's really perfect. If you do non-penetrating surgery, means you manage to avoid this low pressure, then I think non-penetrating surgery is still a better option than tubes. But many doctors don't do that because it's widespread actually in Russia, in Europe, but not in America, for example. And so that's why it has been developed this way.
Okay. And how long does Preserflo remain effective without significant loss of function? Is there solid evidence of its stable performance, or just a way to delay surgery, traditional surgery?
No, we can really consider that Preserflo is a real glaucoma surgery. The point is that it can have a long-term effect, but most of these tubes, like this one or the Xen one, end with a pressure of 15, not of 10. And that's one of the reasons why if you want to reach lower ones, lower pressure, like for in Japan, when there are a lot of low pressure glaucoma and they want to have a pressure of 10 or less, then it's not really the best thing to use. So I would say that it is working well, probably as well as trabeculectomy, but with a pressure which is slightly higher. And there is another issue is a way to handle fibrosis, which is very different from trabeculectomy or non-penetrating glaucoma surgery. The main difference being that there is not a global inflammation of the eye. Sometimes there is, but not always. And sometimes a small inflammation at the tip of the tube may reduce the efficacy. So you have to go back to surgery to take it off. You cannot do just needling, doesn't work. So it's a different attitude toward the follow-up of the patients.
I met some patients who was undergoing with MicroShunt, and in some times doctor put another one microshunt. So they have two microshunts. Is it possible or
Yes,
not?
I have done that also. And in very advanced cases, when you have done the first surgery, then you try in another place to put a first one. So then at this area, you know that whatever you do, there is no chances that you would have no inflammation. So you may try a second one in the lower place, so not at the upper end. It may work. Yeah. So then you get two tubes, but actually the tubes don't, as they don't move, they don't touch, they don't. There is not a corneal problem with it. Not a big deal.
Do you ever cut the tube to make it
No.
shorter to not to touch the endothelium?
Oh no, I think that if it's touching the endothelium, you have to take it off because you are never short enough. Sometimes very short, and even short, they may induce corneal.
Yes, I asked that question because asking from a corneal perspective,
yeah.
surgeon, so many corneal surgeons say the corneal surgeon who also perform glaucoma.
Yeah.
Sometimes maybe they are not used with technique, but sometimes they cut the
Maybe
tube
they
with-
can, but I think that
Yeah.
normally you should really not touch things. So if you begin to touch, I don't know if you make it shorter that it can also touch the periphery. It may be a good idea, honestly, but I don't do it.
Okay.
Should we use mitomycin during the surgery?
Yeah, mitomycin is absolutely mandatory with it. Yeah, and actually now we have done some studies, which is that we should use high dosage of mitomycin, like 0.4 instead of what we usually use 0.2. Yeah.
You have to dilute mitomycin yourself, or in France there is some already.
No, the pharmacy of the hospital is doing it.
Is doing it.
There is one company who market it in America. Actually, it's Metozol. But then the pharmacy has to do it for us, and there are two concentrations, 0.2 and 0.4. And now there are a lot of studies showing that with Preserflo, you can use and you should use higher concentration for a certain amount of time, like 3 minutes or so. Yeah. Yeah, if you don't use it, it's not going to work. I
Okay.
think
So you use it for every patient?
every patient and for every kind of glaucoma surgery. If you have no chance to avoid that.
One more question about technique. Do you do like pocket with viscoelastic in the end of?
No, I don't do
microshunt?
anything. I think the less you do in the eyes, the best it is.
Okay.
Because it doesn't help. Normally, at the end of the surgery, you should have a correct situation. And when you add viscoelastic, usually or inside the eye to make the anterior chamber or larger
not
also.
anterior
Yeah. But generally speaking,
yeah.
the next day the viscoelastic is no more in the area. So I don't think it's necessary. And no, I think because you don't get when you follow your patient the first 3, 4, 5 days, it's always good.
Yes, if it's working and
It's working,
liquid streaming,
and your viscoelastic will not stay there for 3 days. It will go away quickly.
less, I guess,
Yeah.
less. Okay. What are the main reason for Preserflo failure or insufficient efficacy? And can we predict in advance which patient will not benefit from it?
The main reason is certainly the fibrosis of the tube, not inside, but at the tip of the tube. That's definitely the big problem with this. And can we predict that? It's a lot like with other kind of glaucoma surgery. All the patients who have had a long-term inflammatory disease with a bad quality conjunctiva, long-term treatment with eye drops are more likely to have this problem than other patients. The one who have really already very red high with all the drugs without or with preservative may be a very bad indication, but often we have no real choice.
What is the percentage of Preserflo among all of the glaucoma surgeries now for you?
For me, the point is, as I do non-penetrating surgery, I always try first non-penetrating surgery because for the very long term, that's the best issue to get a pressure of 10 for the next 30 years, if you are lucky. But and you will never get that with Preserflo. And it's always my first attitude in case of failure of the first technique. So I think we should keep the idea of this is not the new era of glaucoma treatment. It's an option that if you are easy enough with normal trabeculectomy or sclerectomy, you should first do that. And if you are not easy, or if it has had a failure, then you do Preserflo.
Is this Preserflo MicroShunt good for neovascular glaucoma?
Why not? You can try. Actually, it's supposed to be, is it a good indication like for close angle glaucoma? The answer is if you can put correctly the tube inside the eye without touching both the iris and the cornea, you can try. I have done that in some angle closure glaucoma for some reason. So in neovascular glaucoma, once you have treated the reason why there is that retina for that, you may try it, but I don't think it's a better technique than the other ones. Yeah, it may be an easier one to use, but you get also the same kind of inflammation. So any possible indication. Yeah.
How do you see the future of glaucoma in 10, 20 years?
I see that this last 10 years we have had many new devices. Some are really useful, like Preserflo, like iStent. Some are attempts to make it better, and I'm sure that we will still have other techniques for that. In terms of medical treatment, there have been some new things, like the one Tastudil or why not, but it's not really a big change because it's not very, very efficacious. I see still a lot of new things in surgery.
Okay. Thank you so much.
Yes. Thank you.
Thank you very much.
It's a great honor to have you on our podcast. So,
pleasure.
See you on the third one.